for majority of the time, we have these patients at least on PPAP-5. If you look into ARMA and alveoli trial, the two largest ARSNet trials, they have a very nice table that you can identify with what FIO to what PEEP you need to choose. The other trauma that we can cause by mechanical ventilation is over-distension. So if you use very large tidal volume, these alveoli collapse and open and gets over-distended, and that results significant further damage to that capillary membrane and further leak of volume and worsening status. Indeed, in this quartile of compliance, so this side is lower compliance, this side is almost normal compliance for the lung. So these guys are sicker, these in the middle are half sick, and the one on the right are less sick. As you can see, in the sicker patients, the mortality is significantly higher if you use high tidal volume. So tidal volume should be around 6 to 8 ml per kg of ideal body weight. That is a general mistake that obese patients, we use their weight, which is very wrong. Obesity does not result lung to expand. Lung is exactly the same as size as they were not obese. You have to calculate ideal body weight and calculate tidal volume based on that. Now, this is the modality of choice that we use for majority of our ARDS. We use assist control with volume control ventilation, because if you use pressure control, you generally have a very high chance to give these patients very high tidal volume, particularly when their compliances start getting better. So tidal volume should be about 6 to 8 milliliter per kg of ideal body weight, and plateau pressure should be maintained less than 30 centimeter of water. Now, this is a study came out 3 weeks ago, looked into epidemiology of management of ARDS across the globe. As you can see, only about 70% of patients receive tidal volume less than 6 to 8 ml per kg of ideal body weight among all these patients that they were looking at. And this means that we have a good room to improve our mechanical ventilation strategy. As you remember, I showed you we decreased the incidence of acute lung injury within our institution, and one of the strategies we chose was to use low tidal volume based on ideal body weight. The other factor is to keep plateau pressure less than 30 centimeter of water, and only about 82% of patients with severe acute respiratory distress syndrome maintain their plateau pressure less than 30. If you look into this scatter plot, this quadrant are those who have lower plateau pressure maintained and lower tidal volume. So these are the guys who are going to do well. These guys have high plateau pressure, these guys have high tidal volume. These patients here are the most unfortunate patients. These are not going to do well because of bad mechanical ventilation strategy for these particular patients. Now, what are the other modes that we can use for ARDS? This is an editorial recently, a few years written, and the answer is highlighted in red. There is no other modality apart from what I mentioned that have shown to improve patient outcome. Indeed, there are 143 modalities nowadays available to us as intensivists that we can potentially use, but none of them have shown to improve outcome of patients with ARDS. Now, what are the barriers of a good mechanical ventilation strategy? We can look into age. The older they are, the higher tidal volume they receive. White patients in comparison with non-white patients receive higher tidal volume. Height is protective because taller people, even if you don't calculate their ideal body weights, they receive less tidal volume based on their height. And when patients become sicker, physicians pay more attention. So when SAPS, which is a severity of illness score, goes up, when chest X-ray gets worse, when they are on a ventilator for more than 2 days, when their bicarbonate goes down, they are on more and more better mechanical ventilation strategy. One thing that is important is whenever you use non-volume control ventilator mode, that is a risk factor for not providing a protective mechanical ventilation, because lung compliance changes over the course of the treatment. When lung gets better, compliance goes up. With the same pressure, you can actually give these patients higher tidal volume. Now, what are the rescue strategies? These are patients who have failed our initial management, now they are in trouble. There are 3 steps that we need to take. First of all, ABC, we look into their airway, breathing, and circulation. Sometimes we use neuromuscular blockade agents. Sometimes we have to increase FiO2 in these patients. We need to examine these patients to evaluate their airway, evaluate the ventilator circuit, breathing sound, and pulse, and make sure that they are not in shock state. If we cannot find any good reason, then we need to move to the next step of having more sophisticated tests like chest x-ray to rule out pneumonia or forcing pneumonia or pleural effusion or pneumothorax. Echocardiogram is very important to help us to find how the left and right ventricles do. Venous blood gas and recruitment maneuvers are extremely important. So we need to find if patients are in shock, if their lung is recruitable, if they have right ventricular dysfunction, if they have pulmonary hypertension, pulmonary emboli, if they have lobar atelectasis or left ventricular dysfunction, intracardiac shunt. And finally, after we found what is going on that doesn't help these patients to have better oxygenation, we have to treat each patient based on the result of our test. So if they are in shock, we need to try to manage the shock better. If they have a recruitable lung, and then if they are not in shock, we increase the PEEP. If they are in shock, we can prone these patients. If they have atelectasis, doing bronchoscopy and cleaning up airways would be very helpful. Using inhaled vasodilators for pulmonary hypertension patients are helpful, and we finally use ECMO for patients who have failed all these other steps. If a patient only have pulmonary failure, you can use veno-venous ECMO. If they have cardiopulmonary failure, then you can use arteriovenous ECMO for these patients. Now, there is a study that shows that using early use of paralytic agents can potentially save lives. So patients who have severe ARDS, we do not wait for them to become end-stage ARDS. We start them on 1 day or 2 of paralytic agents, but stop it after a day or 2 when lung compliance improves. There is high frequency oscillator machines that have been looked at by Derdak and et al. In early 2000s. He did not compare HFOs with low tidal volume mechanical ventilation strategy. He used 12 cc per kg of mechanical ventilation in control arm and HFO in other arm, and he found HFO is beneficial. But 2 large randomized trials, Oscillate and Oscar trials, showed there is no mortality benefit. Indeed, there is mortality disadvantage of using high frequency oscillator for patients. What the idea is that these machines give these patients about 50 to 300 breaths per minute with very small tidal volume, and gas exchange happens through convective mechanisms. And this is supposed to kind of keep the lung open, avoid atelectasis. How about inhaled nitric oxide? It is supposed to improve ventilation and perfusion mismatch. As you know, there are significant part of the lung that is perfused, but there is no ventilation in that part. What you do is that nitric oxide goes to the ventilated alveoli and makes those alveoli vasodilated. Therefore, most of the blood shifts toward those alveoli that are ventilated. Therefore, the mismatch improves. As you can see, there is no, in a meta-analysis, there is no mortality benefit found with nitric oxide either. ECMO, this is a CESAR trial that has resulted significant revolution in ECMO. Now, we used to have 1 or 2 ECMO every 6 months. Now we have like 8 to 10 per month. And this is mainly due to follow-up of this study. So these are patients with flu, H1N1 flu, that were treated in England. They had severe ARDS. They were transferred to the central hospital, and they put them on ECMO. Although they did not reach a statistical significance as far as mortality, clinically, they found significant drop in mortality among those who underwent ECMO in comparison with those who didn't. Prone positioning. This is a recent, last couple of years. There are many studies looked into the effect of prone positioning on mortality, and despite the fact that prone positioning improved oxygenation, they did not find any benefit. However, this last study showed significant mortality benefit of using prone positioning early in the course of ARDS. Again, this improves with perfusion and ventilation mismatch and improves oxygenation. Risk would be obviously bedsore and using ET tube. The key on prone positioning is patients usually need very long prone positioning at a time. So if you want to do prone positioning, they have to be at least in prone position for 16 hours a day. Otherwise, it's not going to be that effective. What can we do beyond mechanical ventilation? So one is to prevent fluid overload. So yellow and orange lines are mortality, and green and purple line are length of mechanical ventilation. So as you can see, those who underwent conservative fluid management, they had significantly lower number of days on mechanical ventilator in comparison with those who had liberal fluid management. So they were given fluid as much as clinicians wanted. So we try to avoid further fluid overload for patients with ARDS to avoid longer mechanical ventilation. The only downside of it that was found was changes in neurological status on those patients who underwent conservative fluid management. How about corticosteroids? As you can see in this meta-analysis, there is no benefit of high-dose steroid, but there was some beneficial use of low-dose steroid on inflammatory phase of ARDS. And overall, although the total number of studies didn't reach a statistical significance, there's a favor toward using a steroid on these patients, particularly in inflammatory phase. So if you have a patient who doesn't respond to your general management of antibiotics and fluid management, using low-dose steroid for short period of time is probably advisable. Wake up and breathe. This is extremely important. We do it every single day for every single patient. There's no point to do it more than once a day. You wake up these patients, stop all the sedatives, and you take them off the ventilator in a form of spontaneous breathing or TPs. And then see if they can handle without being on a mechanical ventilator. This has resulted significantly improvement in mortality of patients who undergo this particular procedure. Each time you wake these patients up, you do not need to resume, and if they fail a spontaneous breathing trial, you do not need to resume the sedatives at the same dose as before. Cut the dose in half and restart it for the next day. Try it every day. Do not try it more than once a day. Physical therapy. We started walking patients significantly earlier. We have like 80-year-old grandma who comes to our ICU with ARDS, intubated on pressors. We walk them around using walker. It is very difficult. It needs 5 or 6 physical therapists and nurses and physicians. But these patients come off ventilator a lot earlier, have significantly less cognitive impairment, and they go home significantly earlier. Now, how can we prevent it? This is the checklist that we have at Mayo Clinic. We use this every single time. So we use lung protected mechanical ventilation strategy, as I mentioned. We use aspiration precautions. So when we want to intubate the patient, we invite the most expert person in the room to do it. Otherwise, these patients have high risk of aspiration. We keep their head elevated about 45 degrees. We do a mouth flush once or twice a day with chlorhexidine, and we provide gastric acid neutralization. We use appropriate antibiotics. We limit fluid intake. We restrict transfusion to those patients who have hemoglobin less than 7, and we assess readiness for extubation every single day. Now, switching gears to sepsis. There are a lot of developments in sepsis. So these are my objectives. As you know, incidence of sepsis is rising. These are multiple different studies that they all show upward trajectory of the number of patients with sepsis. And this is mainly due to the fact that patients are aging, they have more comorbidities, they have more diabetes, as previous speakers outlined. They receive more immunosuppressives, as our colleague neurologist mentioned. There are a lot of immunosuppressives that we use nowadays for different etiologies. So the incidence from 2003 to 2012 increased from 300 to about 1,000 per 100,000 patients in last decade. About 1 out of 4 patients admitted in a hospital are admitted for septicemia or sepsis. This is the only reason that they are admitted. However, about 1/3 of patients, they admit to the hospital for other reasons and they are found to have sepsis or septicemia. This is in comparison with acute myocardial infarction. The incidence is going down. For acute myocardial infarction, thanks to all this great preventive cardiology, the acute myocardial infarction is significantly less. So in 2001 was 314 per 100,000, now it's like 222 in 2007 per 100,000 patients. The same is true for a stroke. Stroke is going down. We do have a great preventive measurement for measures for management of stroke, therefore the incidence of stroke is going down. This is not all bad news because despite rising incidence of sepsis, mortality of sepsis is going down. And this is because we are more vigilant, we manage these patients significantly better, therefore mortality is different. So in early 1990s, it was about 46% of all patients with sepsis and septicemia. Now it decreased to 36% in latter part of 1990s, and in the last decade it's been about 25%. So we are living in a different era. So studies that were positive in that time period of time, they may not be positive, and I'll show you an example of it shortly. Now this is another large cohort study of Australia and New Zealand. They showed the decrease in mortality of sepsis by 1.3% per year every single year from 2000 to 2012. Every year we have improvement in the mortality of patients with sepsis. Now, this is the definition that was proposed by a consensus group, Delphi process, 3 weeks ago, indeed. So we used to define sepsis based on inflammatory response syndrome, systemic inflammatory response syndrome, presumption of or confirmed infection, but nowadays we should probably focus on how we can use this new definition to arrange our care. So when you get a patient that is suspected infection, you can use quick SOFA. Quick SOFA is nothing apart from a little high heart rate, a little change of mental status, and a little lower blood pressure. And this test, if it is negative, it has excellent negative predictive value. You can say, no, you don't have sepsis, we just watch you. If this is positive, then there is a chance, small, but there is a chance that this patient may have sepsis. So if you still, it is negative and you still are suspicious about sepsis, then you can move toward using a higher advanced criteria, which is SOFA. I'll show you the table for SOFA shortly. If you don't have any suspicion, you can just monitor this patient. If they reach SOFA scored criteria, then they are septic. If these patients receive volume, some fluid, and they remain hypotensive, need vasopressors, or the lactate remains above 2 milligram per millimole per liter, then you can say these are patients with septic shock. Now this is the SOFA or sequential organ failure assessment score, and if you have any of these criteria, which is 2 and above, patient has sepsis. So if your PF ratio is less than 300, platelet is less than 100, bilirubin is slightly elevated, GCS is less than 12, or creatinine is more than 2 to 3.4, then you certainly have sepsis based on the new definition. However, if you look into the first column, if you have 2 of these criteria, you can have sepsis. So if you have a PF ratio less than 400 but is above 300, and you have platelet between 100 to 150, you still have sepsis based on the new definition. Now, this is a study that was done in a single center randomized controlled trial that revolutionized management of sepsis. This is Dr. Manny Rivers, who identified patients with sepsis in emergency department, randomized them in 2 groups, and at that time, all patients had about 60% mortality in his cohort, in control cohort particularly. So what he said that I want to kind of get the knowledge that is available for sepsis management, put everything into a strategy of managing these patients. So these patients come in the emergency department, they are hypotensive, we place a central catheter, we measure their CVP, if it's less than 8, we give them crystalloid or colloid to improve their CVP. If they remain hypotensive, then we give them vasoactive agents. We give them vasopressors, norepinephrine or epinephrine. If they reach that point, then we measure oxygen pressure, partial pressure of oxygen in central vein. And if that is less than 70, it means that oxygen delivery of these patients is low. To improve oxygen delivery, we need to look into several components. To deliver oxygen, you need several things. First, you need hemoglobin to carry oxygen. You need hemoglobin to be saturated, and you need the heart to pump this oxygen to the tissues. So he attacked those. So if hemoglobin is low, he transfused them. If heart wasn't functioning, he gave them dobutamine, an inotropic agent. And with that, he showed improvement in mortality of patients with sepsis and severe sepsis. For some reason it doesn't advance. Okay. So what he showed was that all patient mortality decreased from 60% to 38%. It's a significant decline in mortality. But remember, nowadays we have mortality rate of about 20 to 25%. At that time, he had mortality of about 60%. It is easier to bring mortality down from 60 to 20 to 25 than 25 to 20. It is a very kind of a good time of the study that was done. He also showed that sicker patients who have septic shock, they benefit from this procedure more than the others. He followed these patients for 28 days and 60 days up to 2 months. They had significantly lower mortality. And patients who underwent this procedure had significantly lower sudden cardiac death. So this is following that study and changes in practice, several surviving sepsis campaign came out. This is the third one, was published in 2013. And they divided the protocol in 2 different sections. The first 3 hours is very simple. Measure lactic acid, do blood culture, give them antibiotics, and give them 30 cc per kg of fluid, and repeat if you feel that patients need it. Right? We will talk about fluids in the next section. And then following that first 3 hours, what happened? Following that 3 hours, it was important to use vasopressors and use the protocols that he mentioned, including CVP and measurement of oxygen in central venous catheters, and remeasure lactate to see if lactate clears up. Now, this protocol compliance improves outcomes. So this is a study was done between 2004 to 2010. As you can see, mortality in yellow line decreased from 20% to 12% when compliance with the protocol improved from 7% to 60%. So if 60% of patients with sepsis and septic shock, they receive such protocol, mortality significantly declined. So this is important to be compliant with the protocol. This is another larger study that shows higher compliance is associated with lower mortality in a larger cohort. This is done in Utah and Idaho. Okay. So recently there were 3 major papers looked into re-evaluation of this protocol, because the question was that this study was done in single center, and we really need to, and there are so many components into the protocol, we need to find out which component actually kind of resulted better mortality. So this is one of them, process trial published in 2014. 1,300 patients, they randomized in 3 groups. One was protocol-based Eligo-directed therapy like Dr. Rivers' study. One was protocol-based standard therapy that was everything apart from that last loop of measurement of oxygen saturation in venous side, and usual care. They let physicians to take care of these patients. This study did not show any mortality benefit. However, mortality for this group of patients was only 22%. So this is a different patient population, and all these patients received earlier attention This is what is actually very important in management of sepsis. The second study compared early go-directed therapy with usual care. Again, no difference. ARISE trial. PROMISE trial, exactly the same. Early go-directed therapy, usual care, no benefit. So these are all different era of management of sepsis. These are all patients who receive care really early. They receive antibiotic really early. The sepsis is recognized very early. Now, when we get to the management of sepsis, there are three most important parts that we need to consider. One is early recognition. So this study looked into the first three things that you need to do, how long it takes to complete that three things. So control was obviously kind of 40% of patients had that in the first 3 hours, but over time the compliance, the green line showed improvement, and so mortality. So the faster you get to the patient, the sooner you can actually improve their mortality. Second is early antibiotics. This is each hour of delay in antibiotic. If you delay for an hour, mortality is a certain degree. When you delay more than 36 hours, almost 100% of patients die. So every single hour is important in management of these patients. We use a test, we call it mom's test. We say that if you would do this for your mom, you do it for your patient as well. And it is extremely important when antibiotics doesn't arrive right time. It's like my mom is suffering. I call pharmacist and say, I need my antibiotics here right now. Every hour counts. So this is another evidence of 18,000 patients and antibiotics. Every hour delay is associated with higher risk of odds ratio of mortality. As you can see, it keeps rising, odds ratio keeps rising from 1.14 to 1.52 over 6 hours. Now, adequate fluid, we are going to talk about fluids in next section, so we bypass this section. A few words on vasopressors. This is the recommendations, the Surviving Sepsis Campaign recommendation for sepsis. To summarize all these notions is that norepinephrine is first choice. If you go up in norepinephrine, you can add vasopressin or epinephrine. Vasopressin should not be used as sole agent. Dopamine, you can use dopamine if your patient doesn't have risk of tachyarrhythmia. Do not use low-dose dopamine for kidney purposes. It doesn't work, it doesn't exist. Also, patients who are on vasopressors most likely need arterial line. Okay, so what are the differences of pressors? Dopamine, it seems that patients who were on dopamine, they had higher mortality, lower survival in comparison with those who weren't on dopamine. Dobutamine didn't make any difference in mortality. Those who were on epinephrine had higher mortality, lower survival, and norepinephrine, in comparison with those who were not on norepinephrine, had a similar mortality. What else can we do? So this is a vast trial. They included patients who were on norepinephrine already. They randomized them between vasopressin and norepinephrine. Mortality, the primary outcome was mortality in 28 days, which wasn't different. However, when they followed this patient for 90 days, they noticed that the curve is kind of being diverged. Therefore, there is potentially some benefit for vasopressin use early in the course of vasopressor therapy. Now, this is just a gist of sepsis talk. Culture should be done as soon as possible, before antibiotic therapy, preferably. Tests, we need to measure lactate for sure. Antibiotics need to be done. Start with broad spectrum antibiotics based on the site of presumed infection, and then you can narrow it down based on the culture results. We have to provide some source control. We remove the dead tissues, the purulent infiltration, and infected devices. Fluid challenge needs to be done early, 30 cc per kg. We need to repeat it as needed. We avoid fluid overload. Vasopressors need to be done. We start vasopressors a lot earlier nowadays, that we don't use a lot of fluid. Steroids, if your patient remain hypotensive, despite adequate dose of vasopressors, you can use stress dose steroid. And certainly limit oxygen exposure. You really want their oxygen remain between 82 to 95%. You do not want to give them too much oxygen because it increases oxidative stress. Now take-home points: early recognition, early antibiotics, and sufficient fluid. Norepinephrine is first choice. Steroid if patient remain hypotensive, and lactate improvement is associated with better outcome. So you need to measure lactate to see if it improves. If it doesn't improve, you're missing something. When our patients do not have improvement in lactate, we call surgeons. We do CT scan. There may be some bowel ischemia is going on that we are missing. So do something to kind of correct that lactate. Lactate is extremely important. Okay, so that takes us to the last part of the talk. As I mentioned, I try to kind of include whatever we teach our fellows in 2 years in 1 hour. So fluid management in critically ill patients. So we have all seen these images, right? These patients come to the ICU with some pneumonia, they get fluid, lung fills out, and then eventually you don't see even lung. And these patients are intubated. Fluid overload is bad. This is vast trial, as just mentioned. They looked into all those patients and they divided them based on amount of fluid balance. As you can see, those who had the highest fluid balance in fourth quartile, they actually died significantly more than those who had lowest fluid balance. So giving more fluid is bad. This is a study that is done in Scandinavia, Finaki study. These are patients who are volume resuscitated, are about to start dialysis. And the more fluid balance they had, the higher mortality they had. So these are groups of fluid balance. As you can see, each bar is higher mortality in comparison with previous one. We know that there is a sweet spot in amount of fluid. So if you give too little fluid, you put patients in danger. If you give too much fluid, you put patients in danger. We have to find this optimal cardiac output. You remember I mentioned 30 cc per kg as the first bolus? This is coming from this study. They looked into different amount of fluid, incremental by 7.5 cc per kg. As you can see, the sweet spot is around 30 cc per kg of fluid. So majority of patients should respond to this amount of fluid. You may be able to repeat it 1 or 2 times, but do not flood these patients. Do not make them significantly edematous because you increase their mortality. Now that's why Dr. Van Son and then following that ATKI group recommended these 4 stages in fluid management. So in rescue phase, you give them fluid to improve their blood pressure and perfusion. And then you try to optimize it. Here and there, you give them a little bolus to make sure that they have adequate amount of fluid. Then when they are stabilized, you just maintain them as they are. You try to avoid further volume overload. And as soon as they get better, they are off vasopressors, you need to remove that fluid that you gave them. Most of these patients, if they have good kidney function, they urinate that out. Majority of these patients have acute kidney injury, they cannot. So you may need to mechanically remove this patient as part of the resuscitation, which is called de-escalation. As important as escalation because volume overload could result further mortality. Now, fluid responsiveness is defined as increasing stroke volume and cardiac output at least 10 to 15% following 500 cc's of bolus colloid volume expansion over 10 to 15 minutes. Fluid bolus is different from fluid challenge. Fluid bolus is when you know patient needs fluid. You give some fluid to patient to improve, 30 cc per kg per hour. 250 cc's is not bolus fluid. 100 cc an hour is not bolus fluid. Do not give them maintenance fluid. These patients just become more volume overloaded. Just give them bolus fluid of about 500 to 100 cc's within 10 to 15 minutes. Then you can evaluate these patients to see if they actually responded to your bolus or not. But fluid challenge is that you don't know if patient is fluid responsive or not. You don't know if you're giving these patients, you can increase their stroke volume or cardiac output. So you try some fluid. It's called baby bottle test, we call it. So if baby cries, you give them some milk. If they stop crying, means that they're hungry. If they don't, then you look into the diaper and then put some varm on the belly and think about colic. So fluid challenge is like that. You give them some fluid to see if their blood pressure improves. You have to make sure that you don't damage these patients significantly. So CVP of more than 15 is usually a limiting factor for fluid challenge. Fluid challenge is a treatment that we use as a diagnostic test, and that can result significant volume overload. If you are on call at home and your intern taking care of patient, and nurse calls an intern every half an hour, patient has hypotension, not making urine. Intern orders 500 cc's 5 or 6 times overnight, patient is 3 more liters volume overloaded, and that can result higher mortality. And indeed, out of all the fluid challenges, only half of them respond to IV fluid. This is a meta-analysis. Only 52% responded. 48% of patients, half of the patients, tolerated the disadvantages of that fluid without any benefit from the fluid challenge. So try your best to identify patients who really need fluid before you actually kind of give them fluid. One thing is that using CVP or static measures of fluid responsiveness is flawed. It doesn't work. So going back to Frank-Starling curve, as you recall, when ventricular preload increases, stroke volume should increase. Therefore, increasing in preload volume should increase in stroke volume. However, if you are on top of the curve, same amount of preload enhancement doesn't result in stroke volume. So same amount of volume doesn't provide the same response. When you use fluids, you need to make sure both ventricles are fluid responsive. If you have a right ventricle that's ballooned out and they cannot work really well, and left ventricle needs fluid, giving more fluid is not gonna make the left ventricle function better. So both ventricles need to be fluid responsive. The problem is that we have many patients with different myocardial function. So if I have a patient with normal heart, increase in preload, it would result significant increase in stroke volume. Patient with failing heart, same amount of fluid does not increase the stroke volume. So you really need to understand how cardiac function is before you actually can do it. There are static measures of fluid responsiveness that is outside of the domain of this lecture, but there are tools that we can use to identify those patients. This is the effect of CVP and wedge pressure on fluid management. There were a large number of patients who responded to fluid, but they had very high wedge pressure and high CVP. In comparison, there were a large number of patients with, who did not respond to fluid. Did not respond to fluid, and they had low CVP, low wedge pressure. Few words on colloids and crystalloids. When you give fluid, you need to make sure that how much of that fluid remains in the intravascular space. Your goal is to enhance intravascular space. When you use D5W, only 80 cc's remains in intravascular space. If you use whole blood, 100% of that fluid remains on intravascular space. This study was done in New Zealand, Australia. Everybody is familiar with SAFE trial. 7,000 patients randomized between saline and albumin. There was no difference in mortality. When they looked into subgroup analysis, patients who had trauma, particularly traumatic brain injury, they did worse in albumin group. But septic patients actually did better when they received albumin as a part of the resuscitation. And in a meta-analysis that was done after this study, it actually reached a statistical significance as far as benefit of albumin in the resuscitation of septic patients. And that's why kind of other studies, including Alboys and chest trial, came out to compare albumin with crystalloids, and there was no significant difference in primary outcome. One thing is that I don't know if in Kuwait you use head starch. You use starch? Yes. Yeah, so starch is dead. So do not use starch. Starch causes higher mortality and higher rate of acute kidney injury. I just put this slide to show you this is something that you should not use. Otherwise, your patient die more, they have more acute kidney injury and need for dialysis. Now, colloid-rich and balanced solutions is a very hot topic nowadays. We know that 1 liter of normal saline has 9 grams of sodium. WHO recommended about 2 grams per day of sodium intake, which means that 1 liter of normal saline has about 4.5 times of recommended dose of salt in a day. And indeed, if I want to kind of picturize that, 1 bag of normal saline is equivalent of 36 bags of potato chips. You remember when you have a patient with CHF, you tell them do not touch potato chips. You're giving 36 bags of potato chips in patients who may have myocardial dysfunction. So probably it should not be used as liberal as it's used now. Now I'm going to show you some evidence. So this is IV fluid composition. As you know, a normal saline is called normal saline. By no stretch of time, normal saline is normal. Normal saline has sodium and chloride concentration of 154 milliequivalent per liter. And normal sodium is 135 to 145. Normal chloride is 98 to 107. So this is not normal saline. It is abnormal saline. Look at the pH. pH of normal saline is 5. What is our pH? 7.4. You can result significant metabolic acidosis in patients who receive significant amount of normal saline. Plasmolyte, Hartmann solution, lactated ringer have significantly better profile of being resembled to the plasma. Chloride concentration is in balanced solution is about normal range. However, normal saline is significantly higher than normal range. Why is that important? We know that this is the afferent arteriole of the kidney that's removed from a mice, put in a solution. They added chloride to that solution. The higher chloride concentration it gets, the lumen of the afferent arteriole gets smaller and smaller. So it can result significant vasoconstriction of afferent arteriole. Particularly look into that 80 to 100, which is our normal range. You can have diameter of lumen of afferent arteriole narrowed down by 8 times when you go from the both side of the spectrum of normal chloride, set aside higher chloride. Now this study looked into 2 liters of normal saline versus lactated ringer after kidney transplant. And the idea was to see what are the metabolic differences and if there is any change in serum creatinine, which they didn't find because of small size. But they found the pH is lower in normal saline, chloride is higher in normal saline, and metabolic acidosis is significantly higher. One question that you may be asked, if patient is not making urine, and should we use normal saline that doesn't have potassium or lactated ringer that has potassium? And this study looked into that, and as you can see, chance of hyperkalemia on patients who receive normal saline is significantly higher. The reason is that lactated ringer has 4 milliequivalent per liter of potassium, right? So you may want to give like 10 liters, and that would be 40 milliequivalent potassium. But majority of the potassium in your body is stored in the cells. When you give normal saline, all that potassium becomes available to intravascular space. You suck a lot of potassium out of cellular space, and that results in significant hyperkalemia. This is an excellent study, randomized trial, crossover. These are normal individuals. They received 2 liters of normal saline or plasmolyte, came back 2 weeks later, and they received the opposite solution, right? So those who received normal saline had higher serum chloride, they had lower cortical perfusion in the kidney, and lower renal blood flow for about 1.5 hours. Importantly, what they found, these are normal individuals. You give 2 liters of normal saline to your medical student, half an hour later they generate 2 liters of urine, right? But this is not true. When they received normal saline, they had higher weight for 4 consecutive hours in comparison with plasmolyte. They looked into where that water is. They noticed that majority of that normal saline ends up in extravascular space. So your idea of using normal saline is to enhance intravascular space, but that results in enhancement of edema and intercellular space. This is a study looked into pre and post using chloride liberal, chloride restricted. As you can see, they showed significant decline in acute kidney injury using low chloride concentration solution. This is a large study of about 500,000 patients received balanced versus unbalanced solutions, and they about 3,300 patients received normal balanced solution, and those who received unbalanced solutions, including normal saline, they divided them based on the percentage of balanced solution they received in comparison with normal saline. For interest of time, what is important is the more saline you use, the higher mortality you have. So 0% is patients who do not receive any normal saline. They receive all balanced solution. When you go to that 100%, there are more concentration of normal saline within the amount of fluid they receive. And the higher normal saline they receive, the higher mortality they have. This is a randomized trial, recently was published in Lancet, very excellent journal, 2,000 patients randomized between normal saline versus plasma light or buffered solution. And these patients were mostly post-surgical, as authors say, and also very low cardiovascular comorbidities. So basically, they gave them 2 liters of normal saline versus balanced solution to people who are normal. Obviously, the effect size would be so small. You usually need 4, 5, 6 liters of solution to be able to see the differences. So this study didn't show any difference between the 2 groups, but the jury is not yet out yet. We still believe that normal saline should be only used in appropriate patient population. So first of all,
3 minutes?
this last slide.
Yeah, okay, good.
Avoid fluid overload. Use fluid based on each individual patient. Fluid is a medicine. You do not use warfarin on everybody and do not follow up with them. Use normal saline on patients who have metabolic alkalosis or they have intracranial hypertension. Do not use it on patients who have sepsis and they have metabolic acidosis. I want to leave you with this quote from Mayo Brothers: the best interest of the patient is the only interest to be considered. And I had a great night last night in Kuwait, beautiful city of Kuwait, and the heart you can see is an example of a great heart of people from Kuwait. I really appreciate your attention.
Thanks, Dr. Kashani, for this extensive review for important aspect of the critical care medicine. And I would like to give we'll leave I think all of us, or most of us, have some question, 1 or 2. We'll leave the discussion towards the end. And I'll give the mic to my co-chair to present our next presenter.
We have reached the last talk of the conference. The last talk is really interesting, although it's not part of critical care, but it's still a critical complaint of patients. Our next talk is about approach to chronic pain management, and it will be presented by Dr. Ibrahim Hadi, who is a chronic pain specialist in Farwania Hospital. Dr. Ibrahim Hadi completed his undergraduate medical studies in Dublin from the Royal College of Surgeons in Ireland. Then he joined the anesthesia residency program at the University of Western Ontario in Canada, which was followed by a fellowship in chronic pain management at the same university. He was the former program director of the anesthesia training program in Kuwait, and I have been lucky enough to be graduated of Kuwait Board of Anesthesia during that period. Currently, Dr. Ibrahim Hadi is the Secretary General of Kuwait Institute for Medical Specialization. And despite being busy in KIMS, he's still running the pain clinic in Farwania Hospital twice a week. Ladies and gentlemen, join me in welcoming Dr. Ibrahim Hadi.
So technical problems, as you can see, is part of any conference.
Okay, good evening, everybody. Well, first of all, I would like to thank KMA and the organizing committee for inviting me to